Hi, I'm Michelle Grzoulis, and I'm president of the foundations at Rochester Regional Health. And I'm happy to be here for our Facebook Live session today with Dr. Christopher Yelverton, who is a dermatologic surgeon at Rochester Regional Health. And it's great to have you here today. Thanks for joining us. Our topic today is skin health, specifically talking about skin cancer and treatments. So I want to jump right in and talk with you a little bit about treatment or skin cancer. I want to invite the audience to ask questions. So if you have any questions, write them in the comments section, and I'll pause periodically to see what's out there. So let's talk about skin cancer, and just give us some stats and data on skin cancer in general right now in the U.S.
So skin cancer has really been increasing. We're seeing quite an epidemic of skin cancer in the U.S. There are about 5 million new cases diagnosed each year, and it's been increasing every year. We're seeing similar stats for both basal cell carcinoma and squamous cell carcinoma, which are the common skin cancers, and also melanoma. All have been increasing pretty dramatically. And in addition to being one of the most common cancers, it's one of the most preventable cancers.
Yeah. And that starts with sunscreen. So we all know, I don't think there's anyone walking around who hasn't been indoctrinated into you need to put sunscreen on. But talk a little bit about why that matters, how much, how frequently.
Yeah, so we have pretty good data now that sunscreen use can help prevent skin cancer. There have been some studies that looked at if you apply sunscreen daily, you can decrease your lifetime risk of skin cancer by about 50%,
Wow.
Which is very impressive.
Say that again for the audience, because that surprises me.
So there have been a number of studies that say using at least an SPF 15 of sunscreen every day can decrease your lifetime risk of skin cancer by up to 50%.
Wow. Okay.
And I recommend at least a number 30, actually, if you know you're going to be outside. 15 is okay for sort of a daily moisturizer or something if you're just kind of running around town. But if you know you're going to be outdoors doing something, choose at least an SPF 30, put it on nice and thick. A recommended amount for your whole body is about an ounce or about 2 tablespoons per application. You want to put it on about 30 minutes before you go outside. And every 2 hours that you're out, you need to reapply.
Whether you're in the water or out of the water.
Yeah, and actually, if you're going to be in the water or doing things where you're really sweaty, you should reapply more often than that.
Okay. I'm so curious about this, the number. So, now you can go to the grocery store and buy SPF 100. Does that, and then people say that doesn't even matter. Once you get past 50, it doesn't even work. What's the deal with that?
So the deal really is there is an incremental increase in efficacy with the higher numbers, so they are more effective. It's a marginal thing. The real key, though, is how much you put on.
Okay.
So, if you take a little bit of sunscreen and you just put it on like that, you're not getting the effect of that whole number. So you really need to be generous with the application. And with that, you can usually get away with a 30 every 2 hours. If you're someone who's very sensitive to the sun, I think there's some benefit to the 50s or the 100s. But the real keys are put it on nice and heavy and pick something that's broad spectrum that covers all the different ranges of ultraviolet rays.
Yeah. What about the things that you read about now, the UV protective shirts and hats? Do you recommend those to your patients?
Absolutely.
Okay.
I think they're a real key thing. And there's so much out there now. You can just go to any sporting goods store and find this stuff, that's designed for golfers or other people that are outdoors a lot. But it works well. It's moisture wicking. It's comfortable to wear when it's hot. And it works great. And especially if you're someone who's sensitive to sunscreen, some people have allergies and things and don't tolerate it. That's a great way to do it. So wear a hat with a big wide brim. Wear the long sleeve, sports shirts. Those things work great.
Before we dive into talking about the specific types of skin cancer, because you mentioned a couple of them, and I want to talk specifically about melanoma, what are some of the other, we know the sun, obviously UV rays, but I want to talk about tanning beds, because those, as long as I've been alive, I've been hearing, not good for you, not good for you, not good for you.
Yep.
I'm sure you agree.
I absolutely agree.
That was a very definitive, he absolutely agrees.
Yeah, and not just dermatologists. I mean, the World Health
Yeah.
Organization's cancer research arm, has classified these as a class 1, tanning devices. And that's the same class as like plutonium and cigarette smoke in terms of potential to cause cancer. So these are really dangerous things and not something that you should use lightly.
Wow. Okay. Good to know. So let's, I want to dig a little bit deeper. You said basal cell carcinoma. What was the other one you said?
Squamous cell
and then melanoma.
And then melanoma.
So describe at a very high level for the audience what that means. What are they? And how are they different from each other?
So those are the 3 main types of skin cancer. The most common is basal cell carcinoma, which is the most common cancer in humans in general. And we see lots and lots of these. Those tend to show up as kind of red, shiny things on the skin, mostly on the face, sun-exposed areas. They're generally very easily treated and very curable if treated early. Squamous cell carcinomas are the second most common type of skin cancer. They tend to be kind of more scaly and rough on the surface. They can be painful. Often they grow very quickly. They do have some potential to metastasize. They can be fatal, so they can spread to organs and lymph nodes and things. But similar to basal cell, if you catch them early, they're very treatable.
And they're pretty localized.
Generally very localized,
Okay.
yeah. And
I'm sitting here thinking that you're looking at my face going, oh, that looks like this. Just a little freaked out. Keep going.
Understandable. So melanoma is the third most common type of skin cancer, and it's one of the deadliest cancers in people. It really is the one that tends to kill people. And the interesting thing that I want to talk about melanoma is the time to diagnosis and treatment is really what makes a difference. So the earlier we catch them, the better. The new study or the new research out from the American Cancer Society says that there are going to be about 180,000 cases of melanoma diagnosed in the U.S. this year. And about 91,000 of those are going to be invasive melanomas, which have the potential to do a lot of damage.
Why do you think that we're seeing so much of an increase? Are we better at diagnosing it, or is there actually more?
I think it's a combination of both. I think there is more. There's certainly, the sun's rays are more intense. We've seen some depletion of the ozone layer and things like that are allowing more ultraviolet light to get to the Earth's surface. I think people generally wear less clothing now than they did 50 or 100 years ago, so there's more exposure when we're outdoors. If you think 100 years ago, farmers were outdoors in long sleeves and jeans and big hats. We just don't see that as much anymore.
It's true.
And then I think, on the positive end, there definitely is better diagnosis. So we're seeing these things, there's more awareness, we're catching them earlier, treating them earlier, and it makes a huge difference. There was a recent study that came out that showed that a delay of even 30 days between diagnosis and treatment of a melanoma can affect people's outcomes in terms of survival, which is important.
So one of the things we always like to try to communicate is, so what do you do? If you see something, what can the average person listening pay attention to on their own skin, and when do they say, I need to go have this looked at? And then I want you to talk a little bit about that whole diagnosis to treatment and shortening that.
Yeah, absolutely. So I think there are a couple of key things. At least half of all skin cancers are going to be diagnosed by the patient or their spouse before they get to the doctor. And then, there are things that we see that they don't see. But the real key things that I always tell patients to look out for, one is if something on your body changes. So if one of your spots changes color or starts to bleed or itch, those are ones you want to get checked out. It's not always going to be something bad, but at the same time, that's a warning sign. And the other thing I tell people to look for is what we call an ugly duckling. So an ugly duckling is just when a spot shows up on your body and it doesn't look like anything else you have.
Okay. We
grow all kinds of fun stuff as the years go by, but the ones that really stand out, those are the ones you want to get checked.
That's actually a really good way to think about it. So melanoma as the most invasive and sort of deadliest, you said, what was the statistic again on the number of new cases?
So American Cancer Society says it's going to be about 178,000 or so diagnosed in 2018. Okay. And so, that's doubled over the last 40 years.
Okay.
It's really
I want to shift to treatment in just a moment, and I want to reintroduce you to the audience. But before we do that, I just want to ask this question as well. So in terms of what you just said to patients or to people listening, watch for things that look different. Then what? Make an appointment with a dermatologist, and don't panic, because it could be what you see could be basal cell carcinoma, could be squamous cell. Yeah. It doesn't necessarily mean it's melanoma.
Yeah, not everything that changes, not everything that is symptomatic is a cancer. Sometimes they're not at all, but those are the ones worth getting checked out. So if you see something that seems unusual, out of the ordinary, definitely give a call to your dermatologist and get in and be seen.
Thanks. So I'm here today with Dr. Christopher Yelverton, who is a dermatologic oncologist at Rochester Regional Health, and we're talking about skin health. And we've spent some time talking about skin cancer and sunscreen. I want to shift gears now and talk about a particular procedure that I'm genuinely really interested in learning more about. It's called Mohs, and it's a treatment for melanoma, correct? Or
it's a treatment for all types of skin cancer, more commonly done for basal cell and squamous cells, and as well as some melanoma cancers.
So educate us on what Mohs is.
So Mohs is just a special skin cancer procedure. It's done in the office on an outpatient basis. It's primarily for tumors of the head and neck, so skin cancers that show up in what we call sensitive areas, areas where they're going to be most visible, where we want to conserve the most normal tissue. And the way that Mohs surgery works, the patient is brought into the room. We numb up the area locally with just some local anesthesia. We remove the cancer with just a small margin around it, and then we have a pathology lab right in our clinic, and we take the tissue and we process it in a special way that we look at actually about 100% of the peripheral margin of what we remove. So we're checking for cancer cells at all of the edges. If we see any cancer cells, we take a little bit more tissue in those areas from the patient. So we kind of map it out and very precisely take little layers of tissue just in the areas where there are cancer cells. And the idea is to save as much of the normal skin as we can, but still get the cancer out with a very high degree of accuracy.
And so compare it to before Mohs, and for folks who aren't treated by way of Mohs, what's the difference? So obviously the margins that you take and the time between the surgery and diagnosis.
Yeah, so there are a few key differences. I mean, number one is that it has a better cure rate. So with Mohs, for most basal cell and squamous cell carcinomas, we get cure rates in the 98 to 99% range, which is better than anything else we have to treat skin cancer. And so really, from a cure rate standpoint, it's important because if we treat it right the first time, it's much less likely to come back, which is great. The other idea, again, is that it's a tissue-sparing technique, so it's going to conserve as much normal skin as we can. So we do this a lot on noses and lips and ears and places where you just can't stitch skin together very easily. And so if we can keep the wound smaller, we can reconstruct it in a way that leaves less scar.
And you're one of the very few people who do this.
Yeah, there are just a few other folks in the area that do this procedure. It's not super common, but it's certainly something that, again, with the increase in skin cancer, we're seeing a lot more of this.
It's great that we're able to provide that as a service to our patients. I know you said head and neck, but if we both had skin cancer on our head or neck, could I be a candidate for it and you wouldn't be? Are there reasons why some folks aren't?
Potentially, although most cancers of the head and neck are potential candidates for Mohs surgery. We try to restrict its use to the most sort of important areas where we're going to get kind of the center of the face and things. If we can get away with taking a little extra margin of skin around it, so if it's on your back or your arms or something like that, we can treat them in other ways and be almost as effective, but not quite as effective. But again, there's always sort of a cost to benefit thing that we're looking at with that.
Okay. You must hear great feedback from your patients who experience this and not have it be as horrible as they might think it is in terms of the impact to their skin, right?
Yeah, I mean, it really, the biggest tell is patients who've had Mohs surgery, if they get another skin cancer somewhere else, they want Mohs surgery because they know that it's effective and it works well and they heal well and they have great outcomes. And that's really great. And it's a pleasure for me to be able to provide that service to people.
Anything else you want to share about Mohs? That you think would be helpful for I didn't know if there was anything else in your head that you'd say, oh my God, I want to make sure I share this.
Yeah, I mean, the other thing to just let people know is, that it's a single day procedure. So you come in, you're usually in the office for half a day or so to get that surgery done. And a lot of that time is while we're doing the pathology. So the idea is you give up a half a day, but your risk of having to have another procedure later on is much less. And that's the idea. So there's always a little trade-off. People don't like waiting around for several hours in the office, but at the same time, they don't have to miss another day of work.
And you immediately know what's happening.
Yeah, and absolutely. And that's really key. It's very, reassuring to me and to the patient to say, your cancer's gone.
Yeah, that's great. Back to the discussion around skin cancer and if you find things, if you're someone who generally has spots on their body, I know the general rule is to see your dermatologist at least once a year, right? That's the general rule?
Yeah, I mean, and it varies a little bit from patient to patient as far as their risk factors. So we look at things like how fair is your skin? How many moles do you have? How much sun exposure have you had in your lifetime? Is there any other skin cancer in your family? Other folks who've had melanoma or other things that are close relatives. And all those things can impact how often we think you should be seen. So it's really if you've never been screened, it's a good idea to get in and see your dermatologist, get a baseline, and then they can kind of guide you in terms of how often you need to be seen.
Yeah, I think you only have to have that happen to you once, and then you're really good about those follow-ups. Share with the audience as well the comprehensiveness of the care that we provide in your service line at Rochester Regional Health.
Yeah, so we've been actively trying to grow the Department of Dermatology here, and we're recruiting all the time, and we've actually grown it even just since I joined. So we have a wide range of services, including general dermatology, which is good for taking care of sort of the medical conditions of dermatology, like acne and psoriasis, eczema, those sorts of things. And they also do general cancer screenings and that sort of thing. And then we have the surgical service line, which is comprehensive skin cancer care, and that's the sort of stuff that I love to do. And then we also have a fair amount of cosmetic services available and aesthetic things. So we have lasers and fillers and Botox and all that sort of fun stuff.
So we can do all the stuff that you need
all the stuff that you need to have done.
Great. Okay, so now the fun part of the program. Why did you become a doctor?
I wanted to be a doctor pretty much my whole life. I mean, probably 5 or 6 was the first inkling in my mind. And it's weird because no one in my family was a doctor. It was just I always knew I wanted to do it. And
interesting.
I know now that I made the right choice.
And why dermatology?
I went to the dermatologist as a kid, and my dermatologist was just the happiest person.
Really?
And I thought, that's a good job. I want that job.
Yeah.
And it's true. It really is very satisfying.
And is it your specialty in that you focus on oncology? That's a differentiated level of training?
It is. So I did an additional fellowship in what's called micrographic surgery and dermatologic oncology, and so basically that encompasses Mohs surgery, other types of skin cancer treatments, as well as some lasers and cosmetics and things too. We do a lot of other procedures, but it's a specialized focused in the Mohs procedure, and you have to do a certain number of cases in your fellowship and that sort of thing to get certification.
Interesting. I'm going to ask Phil if there's any questions. Phil?
At what age should people start getting their full body check? What age frame?
Again, there's not a great recommendation. It really depends on your risk factors. But if you're someone who has a lot of moles, has a family history of skin cancer, or has done things like indoor tanning and those sorts of things, I think, getting seen when you're 18 or 20 is not a bad idea, kind of getting a baseline. Most skin cancers don't develop until later in life, in the 60s and 70s, although we're seeing increasing in young people, a lot more skin cancer in folks under 40. In fact, melanoma is the number 2 cancer in women between the ages of 15 and 30. And so, and those numbers just keep going up, unfortunately.
Yeah, that's terrible.
Can you ask a question about spray sunscreen?
Oh, yeah. Yes. So I would love to know your perspective on whether or not you think spray sunscreen versus lotion sunscreen is there greater efficacy with one versus the other? I have an opinion.
You have an opinion? Good.
It's not at all guided by anything medical.
I think the real key is how you apply it. So I think, if you're going to use a spray-on, get it pretty close to your skin when you're spraying it, and then rub it in afterwards. That's the real key, because often with the spray, especially if you're outdoors, the wind blows it away, and you lose it. You're not getting as much on your skin as you need to.
Yeah. That's a great question. Anything else, Phil? Okay. So I really appreciate you spending time with me today. I would invite the audience, if you have any additional questions, to submit them, and we will come back to you with answers. Dr. Yelverton, thank you very much for spending time with us. Appreciate you being here.
Thank you, Michelle.
You're welcome. That was fun. I learned a lot.